Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. I am so excited to be here today with Dr. Shelley Murphy for our very first ever PEM Chat podcast. And we're going to be discussing bronchiolitis today. But before we get started, I just wanted to take a few minutes and talk a little bit about what my inspiration for this podcast was. So about a year ago, I started searching for ways that we could deliver educational content to the APPs in our department, mainly because we were onboarding a bunch of people, but also for our current staff and potentially for our visiting APP students. And I was thinking about kind of our options of how we could deliver this information. And it just kind of made me think about what is unique about our department, what makes learning in our department a unique experience. And it really boils down to two specific things. And the first one is our physical layout. And the second one is kind of the culture of learning in our group. So number one, we work in an academic center. And we have lots of visiting learners that come through. We have residents from a variety of different specialties. We have medical students. We have APP students. And we all sit sort of in the center of the emergency department. So we kind of sit in this round place. And at any given time of day or night, you'll walk through the emergency department and you're going to hear a variety of different people presenting cases. So it's really an area where we're learning all the time because you're hearing about everybody's cases, and it's a really unique opportunity for learning. And secondly, we teach all the time, but more importantly, we're learning all the time. I believe that we have something really, really special in the culture of our unit because it's a safe space to not know everything. It's okay if you don't know something. It's not a unique experience for people to walk in and we're brainstorming differentials or looking at pictures of rashes or trying to help somebody else that's seeing a patient come up with the right answer or the right plan of care. And if I'm stumped seeing a patient, I will tell a family, hey, I'm going to go discuss this with my colleagues and we're going to make a plan that's right for your kid. So personally, I love this about my job. It's really kind of the coolest thing I've ever experienced in a workplace. And I really wanted to bring that to the learning experience. And that's kind of the idea behind this podcast. So this is a little bit of a homage to our physical design and the conversations we have at work. And basically the format is me or another APP will typically be the host. And we're going to have a conversation with a physician or another APP in our group talking about pediatric ED experiences. And because I worked outside of pediatrics for a long time before coming to the children's ED, it's really my goal to try to highlight what's different about taking care of kids in the emergency department. Because some people are out there in community EDs taking care of kids and they've never worked specifically in pediatrics. And although you might be comfortable taking care of kids, you may not know the little tidbits that we know working in pediatrics all the time. So that's really my goal, is to bring that to the forefront when we talk about these cases. So without further ado, which is what our common first word on Wordle, we will jump into bronchiolitis. And this is something we see all the time in pediatrics, and it can feel incredibly overwhelming if you're not comfortable taking care of it. So welcome, Dr. Shelley Murphy. Thank you for joining me.
Hello. Thank you for having me.
All right. So before we get started, tell me a little bit about who you are and what you do.
So my name is Shelley Murphy. I am an attending physician at T.C. Thompson Children's Hospital. Currently the assistant medical director. Have been doing that job for about a year. But I've been at T.C. Thompson. This is my 7th year. I did my fellowship in pediatric emergency medicine at Vanderbilt and my pediatric residency at UF in Orlando, Arnold Palmer Hospital. I have a husband of 16 years and 2 beautiful girls, 7 and 4. And so I come at this job with both a healthy respect for both being a doctor, but also being a mother. And so a lot of how I treat the families and collaborate with the families have to do with how I myself would want to be treated or how I would want someone to treat my children.
Yeah. So bronchiolitis, What is bronchiolitis? Like, what's the definition of bronchiolitis?
So bronchiolitis is a inflammation of the lower airways in the lungs. So it is caused by a virus. RSV is the one that you most typically hear about, but I would say rhinovirus, human metapneumovirus, both of these are also really prevalent in our community. But basically, you get the runny nose, but then you also have all of this mucus and the cellular destruction occurring in your lower airways. So in the bronchioles, hence bronchiolitis, that can then lead to mucus production and desquamation of the cells and like death of the cells and lots of junk just down deep in the lungs. It's really hard to get out. And this subsequently sounds like wheezing, crackles, coughing, use of accessory respiratory muscles, nasal flaring can lead to respiratory distress, respiratory failure, apnea, and ultimately, death if we can't intervene quick enough.
Yeah. And what age group does it typically affect?
So anyone from birth to about 2 years. I will say after COVID kind of was over, I feel like there was a whole cohort of children who never saw RSV. Like there was the year of COVID, we completely skipped RSV that year, which was wild. But then the following year, I feel like it was even worse because all of these kids who didn't experience it the year before now had it. And we were having like 3-year-olds with RSV bronchiolitis, and it was a wild time. But typically it's going to be kids under the age of 2 because their airways are so small. And so therefore all of this mucus production creates difficulty breathing because it's basically like you're filling up a straw with mucus and they can't breathe.
Yeah, great analogy. So in general, our treatment for these kids is going to vary widely kind of based on their presentation. But what are the like nuts and bolts of caring for one of these kids?
So the first thing in every article you're going to read about bronchiolitis is suctioning. If they can't breathe through their nose, everything's going to be worse, right? There's really minimal things that we can actually do that are effective and evidence-based as far as like the mucus in the lungs. But what we can do is get a really good suction on that nose. That's the first place where air enters the body. And so if that is clear, it will make everything better. And oftentimes we see kids in the emergency room who look really rough, and then we get a good suction on them and suddenly they can breathe better. They can feed because babies are obligate nose breathers. And specifically, you can't really breathe through your mouth while you're drinking a bottle. So they will feed better, they'll breathe easier. And that's going to be the most important thing, is getting a really good suction. After that, it's hydration. And if they're not wanting to do formula or breast milk, switching them to Pedialyte temporarily. And then ultimately, if they are hypoxic, clearly oxygen and additional respiratory support.
Yeah. So are there any diagnostic tests that we need to consider, like when we're assessing one of these kids in the emergency department?
So bronchiolitis is a clinical diagnosis. You don't need a positive RSV or a positive rhinovirus or a positive human metapneumovirus to be able to diagnose bronchiolitis. You also don't need a chest x-ray to diagnose bronchiolitis. These are all extra and oftentimes unnecessary. Unnecessary radiation, unnecessary testing that we don't really need. It's if the kid is having retractions and having crackles and things like that, I mean, that's bronchiolitis. So you can just call it that. So no, not really.
Okay. What if they're febrile?
So oftentimes they are febrile, and it depends on their age, of course, because if they're, a 2-month-old and they're febrile and they have bronchiolitis, you can generally get away with saying, okay, it's bronchiolitis, and then calling it a day. That typically is on that list of like clinically identified diagnoses that prevent you from having to go down the whole rigmarole. I would say if they're under 2 months old, I'm still doing the septic workup because they have had no vaccines. It is also important to know that RSV, for some reason, and we don't know why, there is a correlation between RSV and urinary tract infections. And again, we don't know why this is, because RSV is a virus and a urinary tract infection is a bacteria, and they don't really cross paths. And so we don't really know why one is correlated with the other. But in kids who, have a diagnosis of RSV from, let's just say, the pediatrician's office, is coming to the emergency room a couple of days later because everything's getting worse, and having a fever, I will at least offer to get a urine, because prior to knowing if they have a UTI or not, I would not be giving them antibiotics.
Right.
But if I know that they have a UTI, I would cover them.
So is that any kid that comes in febrile with RSV, or are we talking about girls under 2? Or are you still using those like generic rules for who we get urines on, or is that every kid?
So I think it's depending on their age, and depending on maybe how many days they've had the fever. If it's like day 1 and you have a fever and you have RSV, I might say, hey, keep an eye on this. If, the fever continues and things like that, I would probably have their pediatrician check a urine, or, if you are getting worse, you can come back here, we'll check a urine. I'll offer them to family on the first day too. It's not a huge deal, but if I'm seeing them on like day 5 and they've had fever every single day and the RSV or bronchiolitis is still cooking. I had one of these just the other day. She was 18 months old and had been febrile for 5 days and had RSV from the pediatrician's office. And for her, I did say, like, why don't we get a urine, just to make sure that that's not an additional thing causing her to be sick. And so the evidence is it doesn't really tell you, like, you must get a urine on day 1. It just says, like, there is a correlation.
Okay.
And so it's kind of a vague.
Do you feel the same way about boys?
I think under 6 months, I would feel the same way, but over 6 months, probably not.
Do we routinely monitor an SpO2 on these kids?
So I think if they're on oxygen, I would, or especially if they're like on high flow or something like that. Other than that, we don't. We do spot checks. And so our indication to start oxygen would be if you're awake and your SpO2 is less than 90, then we would start oxygen. If you're asleep and your SpO2 is less than 88, we would start oxygen. We expect their SpO2 to be lower. We know that they're sick, like that is what is going to happen. But oftentimes they've done many studies that show having a lower threshold for starting oxygen has less days on oxygen and less days in the hospital without any subsequent negative side effect.
Sure. Yeah. And it causes such anxiety for everybody.
And the beeping.
Do these patients routinely get albuterol if you're hearing wheezing?
So in my practice, it kind of depends on how old they are and if they've ever wheezed before and if there's a strong family history of asthma. So if the child is covered with eczema and is already on cetirizine and he's 18 months old and mom and dad both have asthma, I'm going to give it a go. I'll try one. But I will be very specific in my before and after assessment. So before the assessment, I'm going to note where the wheezing, inspiratory or expiratory, what kind of retractions we're using, how fast we're working. And then after the treatment, I'll reassess it about 15 minutes later, and then probably again at an hour. Because with bronchiolitis, albuterol does not help. Albuterol at its core relaxes smooth muscles. That is what it does. It relaxes the smooth muscles in an asthma exacerbation that needs to like loosen up the airway and they can breathe easier. That's why they're wheezing. In bronchiolitis, the reason that they're wheezing is because their airways are smaller because of the mucus. And that's why I tell the families, I said, we can try it. Let's try. And if it works, fantastic. We are off of bronchiolitis and we've moved on to reactive airway because albuterol is not indicated for just pure bronchiolitis. So if I have a good story, a good history, and a good, family history, then I'll at least try it. However, if they're like 6 months old and they have no ATP and nobody in the family has asthma, I'm not trying albuterol. It's not going to help. And oftentimes we have kids come into the emergency room who the pediatrician has prescribed albuterol, and the family's like, we're doing this every 4 hours and it's just not helping. And I say, yes,
Time to stop it.
It is not going to help. And, we really wish that it helped and we really want it to help. But every article that's been published in the past 10 years has proven that it doesn't help. It depends on their age, but basically like albuterol is not going to help bronchiolitis.
Yeah. Great advice. So the other thing that I see a lot is steroids. Do these kids need steroids?
So along the same lines as albuterol, if the albuterol is helping, we've now moved away from bronchiolitis and we moved on to reactive airway. For those kids, yes, I would give them steroids because they're not having bronchiolitis, they're having reactive airway. If they're having bronchiolitis, steroids are not going to help. In fact, there's even some evidence to show that steroids can actually worsen your water retention, specifically in your lungs. And so we really don't want to give them that. So no steroids for bronchiolitis.
Okay. So at Children's, we have a really cool protocol, and we use this protocol to navigate bronchiolitis. And Dr. Murphy was actually part of the team that developed that in 2020, which is why she is here to talk about bronchiolitis today. But before we talk about navigating the protocol, I wanted to just have you talk about what did life look like in the emergency department before we had a protocol?
So I like to describe that time as the wild, wild west of bronchiolitis. We would have, so everybody practiced differently depending on like where you trained and what the kid looked like. And we had no specific scoring system. We had no specialized like suctioning tools. We had no way to objectively determine who was what type of mild, moderate, severe type of patient. It was vibes. You went on vibes. And so you're like, that kid looks like he could use a little oxygen. And so we did oftentimes this like low flow, high flow thing where instead of like giving them oxygen, because they're not really these kids were not hypoxic, but they were having just like increased work of breathing. And so in order to almost like admit them to the hospital for observation or just to see if it might make them feel a little better, we'd put them like 1 or 2 liters, even though they were not hypoxic. It was just their work of breathing. We did that a lot. And especially if we had a kid who we just didn't like the way they looked, we would do that often to like admit them to the hospital for observation. There was no kind of way to say like, hey, I'm just admitting this kid for observation because I don't like the way they look. Like you had to prove why. And so we would start them on like low flow, high flow, just to kind of watch them.
Yeah. And I can imagine like selling that to the team, like, I just have a bad feeling about this kid, or, the subjectiveness that would look like between like each different provider. And I'm sure there was this like, are you comfortable managing bronchiolitis? A lot of different interplay there.
Yeah. And there was a lot of pushback during that time and a lot of stress and strain. And so that's why we came up with this protocol.
Yeah. And I love it. I wasn't familiar with it before I came to Children's and didn't have to manage a lot of broncholytics, thank God. But wow, this really...
Not too many broncholytics in OB/ED?
No, or at East, thank God. Because I'm not sure I would have known what to do. It would have made me really nervous if I've got this baby that's distressed and I don't really have any like way to figure out what to do. So the protocol is great. And I'm going to link there's going to be a link in the show notes so that you can look at our scoring tool and also our protocol. But the bottom line is a kid comes in and looks like a broncholytic, and the nurse automatically recognizes that and will score this patient and give them a score. And it's a score of 0 to 12. After she scores that patient, by protocol, she will suction this patient, because we all know that that's the first thing we're going to do for any baby that presents with bronchiolitis. And then the goal would be for the provider then to see the baby about 15 minutes later, and then we're going to rescore them. So we have this pre-suctioning score, post-suctioning score, and we can kind of see where they fall on our protocol for treatment. So it's divided into 3 categories. We have mild, moderate, and severe babies as far as their score goes. So just for ease of discussion, we're going to just kind of talk about each category. So what does a mild broncholytic look like?
So mild bronchiolitic, typically they can be breathing like a little bit fast. So this is going to be a score of like 0 to 4. So they could be breathing slightly fast, or they could be having just some subcostal retractions or belly breathing, as some people like to say. Or they could have maybe not be feeding great, but still feeding at least 50% of their feed. Or they maybe have a little bit of crackling. So they can have one of each of those. So these kids, that would be a score 4. And so these kids are sick. And that's why I tell the families, I'm like, yes, your child is sick. And I'm sorry that your child is sick today. And I'm sorry that you are not going to get a lot of sleep for the next 5 days. I'm sorry. But they're not so sick, which is great. They are not so sick today that they need to be in the hospital. This is something we can manage at home. We're going to show you how to take care of it. We're going to show you how to suction. These are the kids that we would send home with a bulb syringe, show them how to suction, have them show us how they suction. We make sure that they can drink either some Pedialyte or formula or breast milk. And then typically I have them follow up with a pediatrician in like 1 or 2 days. It also depends on where they are in their illness. So if it's day 1 of RSV or something like that, and they're a 4, I'm going to say, okay, this is probably going to get worse before it gets better. Please see your pediatrician tomorrow, or come back here tomorrow if you can't, or, for whatever reason, and we will check them out again. Because it will get worse before it gets better, right? That is the nature of bronchiolitis.
Yeah. And if you're not familiar with like the course of RSV,
yeah,
that's kind of what she's talking about.
Typically with RSV, the worst days are going to be days 3, 4, and 5. I feel like each year, each round of it is a different day. So like last year, day 5 was the worst.
Yeah.
But the year before that, day 3 was the worst. So it's like day 3, 4, 5. And so, with RSV specifically, like I'm going to tell them it's going to get worse. Whereas like rhinovirus is more like on day 1, 2, that's when it's going to be at its worst. And then it will get better. So that might be one reason that you might consider getting an RSV test. But it doesn't super change the conversation, because really bottom line is if it's getting worse, please come back.
Yeah. And parents have such anxiety about RSV. I feel like lots of people are getting RSV tests just because it makes mom and dad feel better.
Yes.
Okay, so these are kids really that can go home, but they have to kind of prove that that parents can manage their secretions and that they can feed appropriately.
Yes.
But they're in a low, mild category. So these are kids that could potentially go home.
And I'll also bring the protocol into these families, because oftentimes the parents are really worried. And I'll say, hey, we have this protocol. Let me show it to you. This is where your child is. They're going to be okay. Like we're going to follow up with the pediatrician. And also before I send them home, pretty much to everybody, I tell them, and if it gets worse, come back.
Yeah.
We are open 365 days a year, 7 days a week, 24 hours a day. We are always here. And usually they laugh and, some rapport is built. But like keeping that door open, I feel like makes the family feel better that it's okay if they come back. Like
Absolutely.
We're not going to be mad. And I'd much rather them come back 4 times than wait until the kid needs to be intubated.
Yeah, absolutely. This is so funny. I treat this kind of like I did preeclampsia in the OBED, which is where I worked in my former lifespan. But, people have to come back sometimes days and days in a row for labs because we want to keep you pregnant as long as possible, but we want you to be well. And so I tell parents the same thing here. Like, I don't want to put you in the hospital if I don't have to. I think your baby is well enough to go home right now, but we are absolutely here and you may have to visit us again. And that is okay. We want to see you and we want to make sure your baby's okay.
Absolutely.
All right. So for our moderate kids, these are kids scoring 5 to 7. Tell me about this group of kids.
So for the moderate kids, everything's just like a little bit worse, right? So they're having maybe subcostal, intercostal, and suprasternal retractions, or they're breathing even faster. These kids sometimes won't feed. Even when you suction them, they still are just like, I'm not feeding. Or when you listen to them, there's wheezing, there's crackles. These kids are just more sick. Like everything's just a little bit worse. And they sometimes will still feed, but oftentimes won't. And so for these kids, we do just observe them in the hospital. And that's what I tell families when I'm admitting them. They're like, well, what are you going to do in the hospital? I said, well, we're going to suction every 2 hours. We're going to score every 2 hours. And then that way, if, for example, the baby stops feeding or the baby decides that they want to start getting into the severe category, you all are here. We're watching very closely. We're making sure that we don't get into the severe category. We don't get dehydrated. We're just monitoring for worsening symptoms.
Yeah.
And then, if they are not feeding, then we can drop an NG. We can feed them breast milk or formula or Pedialyte through an NG, or we can do IV fluids.
Okay. And just in case it wasn't clear before, when we make these management decisions, we're talking about the second score, right? So a lot of these kids will come in and have a really high score, like they'll score an 8 and look terrible, and then we suction them and they're a 1. It's pretty incredible what suctioning does. So just remember when you're assessing this patient, it's not on your initial look-see. It's going to be on this post-suction. How do they look? How do they act? How do they feed after that suctioning event so we can make these clinical decisions?
And in this moderate category, they get the initial moderate score, and then we observe them for an hour.
Mm-hmm.
So this is an even longer observation period because we really want to make sure that they are actually needing to be in the hospital. Just depending on the baby's affect, sometimes they're just really fussy when you see them, or they just refuse to feed, and then you watch them for an hour, and now they have a score of like 1. So in this moderate category, we watch them for an hour before we decide whether or not we're going to admit them to the hospital or not. And then once they're admitted, they watch how they're feeding, resuction, rescore, things like that before they show and prove that they're getting better and not worse, and then ultimately discharge home.
Okay. In this category, we talked a little bit about IV fluid support or NG tube. How do we make the decision in these babies if I'm going to go with the IV fluids or if I'm going to do an NG tube?
Yeah, absolutely. So oftentimes I'll let the families decide, kind of a shared decision-making moment. If they feel very strongly about one way or the other, then we'll go in that direction. If they ask me, if they say, well, we don't really care, what do you think? The evidence has shown that if we feed them enterally, so with an NG tube, either breast milk, formula, Pedialyte, things like that, they get better faster. We're using the gut. They're feeling more full. They're happier babies. And so they get better faster. So if all things being equal, that's what I would lean towards. However, if I have kids who I think might need to be going on to high flow, or if they're just vomiting a lot, I wouldn't feed them. I would do an IV for them instead, because if we're going on to high flow, we really don't want to feed the gut because there's going to be air that's kind of circulating in that area. They're more likely to vomit and aspirate.
Yeah. And if you're not familiar or comfortable doing NG tubes in kids, they're really pliable, soft. It's nothing like placing an NG tube in an adult where it's like this really hard tube and it's very uncomfortable. So we do that quite a lot in pediatrics, and it's a great adjunct for these kids that are just too tired to feed. Okay, so let's move on to the severe category. What do these kids look like? How are we treating them?
Yeah, so these kids come in, and these are typically the ones that the nurse is coming to get you to come and see. They look bad. They're breathing really hard, really fast. They're lethargic. They're not, opening their eyes really well. They, and I would say, please get up and go see them straight away, because they've been sick for a while. They've not, they didn't just wake up like this. They've been spiraling downward for probably a couple of days. These kids, when you listen to them, they've got wheezing, crackles. There's a cacophony of noises happening in their chest.
Awesome word.
They're retracting subcostally, intercostally, suprasternally. They're nasal flaring, their head bobbing, or they're not breathing at all. They're apneic. They're having periods where they just are too tired to breathe. They might be lethargic. They probably look a little dehydrated because they haven't been feeding as well. But these are the kids that they look rough. And then they've suctioned them, but it still really hasn't changed anything. And so for these kids, we go ahead and just start them straight on to high flow. High flow is a very cool machine that is through a nasal cannula, and you can turn up the rate at which you're delivering oxygen, humidified oxygen, and you can actually like dial up and down the amount of actual oxygen. So your FiO2, you can kind of play with it and deliver the amount of oxygen that they actually need, because oxygen is medicine, just like everything else, and we don't want to give excessive when we don't need to. These kids, it's humidified, so it goes in a lot nicer. The way I explain it to the families is kind of like driving with the windows down in your car, where you just have like the wind rushing at your face. And the way that this works is it helps to stent open your alveoli. It helps keep open your lower airways so that they don't have to work as hard with every inhalation to come up, get over that initial like effort. It's just always open, so it's easier for them to breathe.
Yeah, great description. I love that. And tell us how to do, like, what are our initial settings if we're going to start high flow? And on a side note, if you are familiar with vapotherm, this is the exact same thing. We just call it high flow in the PEDS-ED. So how do we set this?
So it's going to be 2 per kilo. When we came up with this protocol, we had a lot of studies. We looked at a bunch of studies to see like where we should start this. And ultimately, the bottom line was that if you're going to do it, like do it properly. So we start at 2 per kilo with a max of 20 liters. And so that has been found to have the least amount of days needed on high flow, has had the best outcomes. And ultimately, there's no adverse event from starting that high. So we have pretty good standards for the children who need this, so that when they need it, they need it. And so that's why we start at the high flow, high level.
Yeah. All right. And in this category, some of these kids need to be intubated. Who, when I'm looking at them initially in my initial assessment, who needs to be tubed immediately?
So I think kids who are not protecting their airway, as in they're having apnea after apnea after apnea, they're very lethargic, they look septic, they look ill, those kids are getting intubated straight away. Sometimes you can start them on high flow and they'll start to perk up and they'll start to drop their CO2 to a more reasonable level, and they'll start to turn around. And sometimes that's all you need is a bit of stimulation. And they can cruise on high flow and don't need to be intubated. But then you have the kids who you start them on high flow and they're just not getting better. Mm-hmm. They're still retracting. They're still tachypnic. The CO2 is climbing on your blood gases. We get them every 90 minutes after we start it. And it's getting worse and not better. Those kids need to be intubated.
Yeah, I had that happen just last week and she just didn't turn the corner. So off to the trauma room we go. Mm-hmm. All right. Little bitty babies in this group?
Yeah, so 3-month-olds. For some reason, kids under the age of 3 months seem to have a higher risk for apneic episodes. So these are episodes where they truly stop breathing for 20 seconds or greater. And typically they can turn pale, gray, blue with these episodes. And I will ask the family, I say, did they ever stop breathing at home for 20 seconds or more? Did they turn gray or did they turn blue? And so if a family tells me that they did those things, they're getting admitted straight away. We don't know why kids who are 3 months, under 3 months or premature seem to have a higher risk for developing apnea. They've studied, they've done lumbar punctures and looking for RSV in the meninges and still, it's not there. So they don't know why this causes it. And the CO2 could potentially not even be that high, but they're still having apneic episodes. So really kids who are 3 months and older, younger, keep a close eye on them because they're the ones that will just stop breathing.
Yeah.
And where I used to train, they would admit kids, any child under the age of 3 months who had RSV.
Yeah. Kind of a scary group. All right. So I know you've had a horrible case. What's the worst case you've seen in a bronchiolitic?
Yeah. So I had a kid a year ago or so who came in. She was in the severe category. We suctioned her. She was still in the severe category. So we started her on high flow, put her in the trauma bay. And she just wasn't getting better. She wasn't moving good air. She was still tachypnic, still retracting, CO2's going up. So we intubated her. It was a lovely intubation, very controlled. And then all of a sudden, when we're shooting the x-ray to confirm the ET tube placement, she codes. And in that moment, we got the chest x-ray that demonstrated a very significant tension pneumothorax. We didn't know it prior to the x-ray, and but she coded. Now, of course, she coded right in front of our very eyes. So we immediately started CPR, gave her, I think, 2 or 3 doses of epi, and we got her back. Like it was very quick turnaround, quick ROSC. But she ended up getting, so she had her tension pneumothorax, which we needle decompressed immediately. She ended up tracking air all the way down into her abdominal cavity. So she ended up with a chest tube, an abdominal tube, went to the PICU, and then like several days later went home.
Yeah,
without any deficits.
Wild. Every time I hear about it, I'm like, wild. But if you don't know Shelley, she's a little bit of a dumpster fire or a black cloud, if you will. And, if things are going to go wrong, she's probably going to be there.
Smooth seas do not make strong sailors.
True story. True story.
All I have to say.
And you're an awesome attending. We would be remiss if we did not talk about broadening or differential in these cases. There are plenty of things that mimic bronchiolitis. And of course, when we're assessing this baby in the very beginning, these are the times when you're thinking about those things, kind of ruling them out, so that we can make this clinical diagnosis. But let's talk about some of those things that mimic bronchiolitis.
Yeah, absolutely. So, just a few months ago, I had a patient who was probably about 13 months old and, runny nose, cough, congestion, wheezing, all the things, retractions, moderately bad. But I look at the kid and he's covered in eczema. And I just said, does anyone at home have asthma? And Dad's like, yeah, I have terrible asthma. I've got my inhaler right here. I said, okay, well, why don't we just try an albuterol treatment? Let's just try. It may not work. It may not do anything, but it's not going to be dangerous if it doesn't do anything. And so we did it. And I will tell you that kid sounded amazing afterwards. So not only at the 15-minute mark, but an hour later, still looked great. And so I said, okay, this is not bronchiolitis. This is reactive airway. Here is your dose of steroids, because again, we are reactive airway. Here is your albuterol inhaler with your spacer. Very important to use the spacer. And so the family was like, okay, great. And then I was able to discharge them home. Whereas if I had just been like, oh, well, he's a moderate bronchiolitic, admit him in the hospital, he wouldn't have gotten better.
Yeah. Yeah.
So that was a time when, it was reactive airway and albuterol did help. Another patient I had just a couple of weeks ago, he had been seen a couple of days earlier, had a fever, runny nose, cough, congestion, diagnosed with an ear infection, started on amoxicillin, but had come back because now he was having difficulty breathing. And I listened to him and he sounds pretty rough. He's got bronchi everywhere. He's retracting. He's kind of borderline grunting. And so I said to my respiratory therapist, hey, can you get a really good suction on him? Because he just sounds so mucusy, there's just so much in there. And she's like, sure. So she suctioned him and it didn't really do a whole lot. And I was like, no, deep suction, with a suction catheter. And she's like, I'm not super comfortable doing that for this patient. It sounds weird. He sounds weird. I was like, okay, that's fine. So I got a chest x-ray because we've been seeing a lot of pneumonia right now. And that's kind of what I was looking for, which is another thing that can happen in kids who have bronchiolitis. And, especially right now, they can develop pneumonia, or it's also on your differential. But he just sounded so awful. And so I got a chest x-ray on him and he had swallowed a coin. And so it was just, the mom was flabbergasted.
Yeah. And you were too, right?
I was also flabbergasted. That was not what I was looking for. And so, thinking about, we don't always get chest x-rays on bronchiolitics. And so he just didn't fit the normal pattern.
Yeah.
We suctioned him and it made no change whatsoever. So it was that there was a foreign body lodged in his throat, and that was the noises he was making. So he went to the endoscopy suite.
Wild. Heart stuff?
Yep, always heart stuff. Definitely not all wheezing is asthma, not all wheezing is bronchiolitis. Some wheezing is congenital heart. These kids, I think asking and listening to the history and doing a really good physical exam. Of course, that's what we always say. If these symptoms have been going on for 3 days, it's probably bronchiolitis. But if it's been going on for weeks and weeks and they're edematous and they've got pitting edema to the feet and they've got gallop, it might be a heart problem. It's not always bronchiolitis. And the thing that is one of the hardest things about our job is, in the middle of bronchiolitis season, when it's bronchiolitis, foreign body, trying to pick out who is not matching the typical pattern, who is not following that bronchiolitis script and following those instincts of like, this feels different.
Yeah. That little voice in your head that's like,
but is this really?
Yeah.
Yeah. So those are the things that, just listening to yourself and, heart and lungs and physical exam and checking for peripheral pulses and making sure that you're examining the majority of the child, not just the lungs.
Yeah. Doing a good physical exam. Okay. So in an ideal world, somebody calls you from an outside facility. They want to send you a bronchiolytic baby. What do you hope they've done?
So I really just want them to get a good suction, really. If you can use some saline and a bulb syringe to clear out that nose, that would be great. That's all I want. I would love to hear a good physical exam. I would love to hear crackles or retractions or a respiratory rate, just to kind of give me a general idea of how this kid looks. Because, telling me that, oh, this kid looks really bad doesn't give me any sort of objective data. But really just a suction. That's all I need. And if they still look bad, please send them to me.
Yeah, this is one of those weird cases where doing a bunch of tests and doing a bunch of medicines is less important. Really, we just, want the basics here.
Yeah, because I'm not going to do any of those things either.
Right.
Like I'm not, if they feed, but they look bad, I'm just going to admit them to the hospital.
Well, I think from having worked in an outside facility, you want to be able to call the attending and be like, hey, this is what I've done, and they haven't gotten better. And that's sort of the habit of when you're working in a community facility. So the take home here is, back to the basics on this case, like just suction this baby and be able to describe what their distress looks like and give us a call, and we are happy to see them. All right. So kind of as a brief recap, we're going to just talk about like pitfalls and pearls in these cases. And we've talked a lot about this, but this is just like a brief summary, keeping it simple, like back to the basics here.
Yeah, absolutely. So I tell families at home and I tell pediatricians and I tell everybody that will listen, just suctioning every 2 hours. Saline, everybody wants to buy the like $6 little noses type saline spray. And I'm like, no. Just buy the 97-cent like adult ocean mist. It's fine. Just turn the bottle upside down and it makes drops instead of a mist.
Oh, I didn't know that. I did not know that.
Ryan told me that. My husband, Ryan, who's not medical at all, he's like, if you just turn the bottle upside down, it becomes drops. And I was like, no, you're lying. And we did it. And I said, wow. So I tell families that they don't need to buy the fancy pediatric saline. They can literally just buy the adult ocean mist, Walmart brand, 97 cents, turn the bottle upside down and it's drops.
Good to know.
Instead of, and I like drops versus a mist because like, I feel like a mist is nice to end with just to like give you some moisture, but it's not going to be enough to like break up the thick, socked in there mucus that's going to be obstructing the airway. If you want to finish with a mist, sure, that feels lovely. But, or like, like a humidifier. You want a humidifier going? Why not? There's no evidence to show that is going to be super helpful. I like it because it makes me feel nice, but same. It's not going to keep your child out of the hospital, right? Suctioning and saline is going to keep your kid out of the hospital.
Yes.
So that's really, and I say every 2 hours, especially before feeding, because again, babies have to breathe through their nose in order to feed. And then, telling the families also like, when you have a runny nose and you have a cold, like right now, when you have RSV also probably, how many times a day are you blowing your nose? And they're like, just constantly. I'm saying, I know. So your baby can't blow their nose. We have to do it for them. So I think asking every 2 hours is not unreasonable.
Yeah. Do you tell them to like elevate the head of their bed or?
I can. I do sometimes, especially like reflux too. But like, if you're going to do that, you definitely want to be very, very clear as far as like blankets and pillows under the mattress.
Yeah. Okay. So suctioning and where were we?
Saline and suction, Pedialight's okay. It's only temporary. We're not really worried about them like gaining weight, making weight for their wrestling match. We really just want them to like stay hydrated and stay out of the hospital.
Yeah, about volume. With goals for feeds, you mentioned this earlier. Is it you want them to be taking in at least 50% of their normal volume?
Exactly. That's one of our discharge criteria on the protocol is, if they're feeding 4 ounces every 4 hours, but right now they're only feeding 2 ounces every 4 hours, that's okay. They're staying hydrated and they're making 4 wet diapers in 24 hours. That's kind of like our baseline minimum urine output. Those are like my reasons to come back, right? Like if they're feeding less than that or if they're making less than 4 wet diapers, come back and we can check on them again.
Okay. Fantastic.
Yeah.
Thank you so much for joining me today.
You're welcome.
All right. Till next time. Thank you for joining us here today at PemChat. I hope you enjoyed today's episode. Please join us next time when I'm going to be speaking with Dr. Tamara Davis about preseptal and orbital cellulitis. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.